Okay, welcome everyone. Can I ask you to use the comments and questions feature in Zoom so that we have a list of issues and questions, and also you might be able to share comments. And in 30 minutes, we'll open for general discussion. So this session is an invitation to join in developing something that I'm going to call rapid implementation research. And some of us in Sweden and internationally think that implementation research has a lot to offer to services to help them make changes to respond to emergencies, but also that doing so will also help us develop implementation science in different ways. Now, we're working to help our services prepare for the winter resurgence and the health consequences of this continuing crisis. And I'm going to use our project to give an example and share some of the challenges that we faced and our resolutions and what we learned about implementation knowledge and research methods. The subject then is implementing emergency management in all of primary and community healthcare services in Stockholm, which is our capital city. First, I will give some background and then the story of the project so far, and then we can discuss the implications for implementation research and practice. So, on the 31st of January this year, the first infection was registered in Sweden. On the 11th of March, the first COVID-19 death was registered in one of our Stockholm hospitals. On the same date, the WHO declared a global pandemic. Now, this is one of the many comparison sites in May this year that showed Sweden up there with the UK of amongst the highest number of deaths in per capita. This is highest death rate per capita and comparable to the UK. But what was not comparable were the two governments' public health responses. Now, in that, and that's a different thing to how the healthcare responded, the hospitals and primary healthcare. The public health response is different. Now, it's better to compare local responses, and what I'm going to do is compare London and Stockholm, the two capital cities, and this is more of an apples to apples comparison, although it's a slightly different variety of apples. And what we saw in London was this complete lockdown, and in Stockholm there was none, essentially. And I would characterize our response as hard and early in healthcare, but not in a mandated public health. And some of that's explainable because we do our public health approaches differently, and we can talk about that later. But the focus of this really is on implementation. So I won't be going into that. Whereas I think London was hard and late. I think you left it at in my estimate, two to 3 weeks too late. I think the Imperial College researchers frightened the Prime Minister with the projections they were seeing, and they switched, they did a U-turn. But I think also that your healthcare response was variable. We have a much more integrated health system in Stockholm compared to London, which is much less integrated. What explains this? I'm not going to dwell on this and just give you some speculation, because our subject is implementation, but I really can't go onto that without answering some of these questions that we've had from everyone. is it simply differences in data registration? Well, I think there are definitely big issues in that area, but especially in registering deaths from COVID outside of hospitals. I think we and you miss a lot of these. Is it something to do with the population density? Well, I think overall in Sweden, there's a much lower population density, but if we compare our two capital cities, it's pretty similar. Housing and overcrowding, I think that's pretty similar. We have, I think generally the standard of housing is slightly better, but the overcrowding, the multi-generational occupancies is fairly similar with some shared low-income apartment blocks and similar immigrant areas. Is it generally the a healthier population? I think probably not. It's possible. Is it because the Swedes are more Germanic in their rule following? I don't know about that. I don't think so, really. Is it something to do with the local healthcare that explains the death rate as opposed to the infection rate? Well, I think potentially there is, and that's part of what I'm going to talk about. And I think especially how we implemented changes in primary and community healthcare rapidly and effectively. And I think that really kept the pressure off the hospitals. And I'll talk about that later. That's why I think the implementation issue is so important. But what both London and Stockholm failed miserably in is the many deaths amongst older people in residential homes and living at home, and also the high infection rates of care staff. And I think that was a failure of implementation, and I can explain and discuss that later. And this is, I think so far this century, this is the biggest failure of our health system, and a call to action to everyone, especially for the winter. I'm proposing and working on a program that I'm calling Zero Infection for older people residential services. And I'll talk about that some other time, but implementation is a big issue there. So I'm going to move on to really the main focus of this, which is our project. Now, our project started in early March. Before that, I saw an important opportunity. My own background is I work 50%, I'm in a 50% employee of Stockholm, a government employee of Stockholm Healthcare Region as R&D officer there. And I'm a 50% employee of Karolinska Medical University, one of the research groups there, and I have been there for 15 years as Professor of Implementation. I also have 30 years experience in quality improvement and implementation and evaluation on the sort of the practical end. And I heard the Nordic gods saying, look, we gave you all of these privileges and skills. Now's the time you need to use them with a vengeance, because this virus is not of our making. So also, I think another item is that we need to do something that's, I felt that we could do active action research that's relevant to the decision makers to help with the implementation. But I was aware that we had very limited resources to do that. All of our researchers and staff were full-time on other projects, and we part of the story is that I had to cobble together a team of 7, and it was a joint team in Region Stockholm and at the Karolinska, our medical management centre. And all of these volunteers, so-called volunteers, were not funded, but they rose to the challenge. I must admit, I had to develop very rapidly some leadership skills to sell and maintain their involvement, given that they were full-time on many other things. So we were able to fast track the ethics. Within 10 days, we got ethics approval. And our first challenge was, well, okay, we've got this broad plan for research, but we need to focus it. We need to focus on what's feasible and useful. And what I'm going to do is tell you some of the things that helped us focus the project into to be able to use our implementation knowledge and skills for a practical value to be used rapidly. And in a very simple sense, what the various implementation science concepts really helped us sort out what was doable and where to focus and which data to collect. And these concepts are known to most of you and have been covered in this masterclass. The first 2 maybe not so, but certainly the context and implementation outcomes have been covered in some of the frameworks, and I'll mention that. But what was most important to begin with was to separate the intervention from how the intervention was implemented. Some people call the intervention the what, and the how the intervention implemented as the how. And the intervention is something that was not done before, but it's a new, better way that is needed by this situation. And what happened from March the 1st onwards, very, very rapidly, is hundreds of interventions were implemented, and some of these interventions were evidence-based and some had very little evidence. For example, at that time, the CPAP, positive air pressure treatment, there wasn't a lot of controlled trials on that, but we'd learned from our Italian colleagues and others the value of this, and this was a way to prevent having to go on a ventilator, which has to be avoided at all costs. Secondly, the obvious ones of PPE, that's an intervention, is masks and protective equipment. A third type of change was the testing and also changes to flows within clinics where people visited. So these were all new, better ways that didn't happen before and suddenly had to be introduced. And what we're going to focus on is how these were implemented. And what were by that I mean, what were the actions that were taken to enable people to take up these new, better ways correctly in their everyday practice, because they hadn't done any of this before with a vengeance like this. And some of the things that helped were mandates, directives. Some was training and feedback to introduce the new, better ways, and I'll talk about these later. So the focus is on implementation and what helped and hindered taking up these changes. Now, where were we going to focus? what we could have done is focus on the clinical practice level and just looked at testing and these clinical practice changes and how they were implemented. Now, I think that's reasonably well covered, but there's certainly scope for that, more on there. The second level is unit management. So these are the managers of the clinical practice teams, like, for example, a manager of a primary healthcare center. And these unit managers had to rapidly convert their services, telehealth, introduce these new physical flows. Many of them had new staff or staff taken to be reallocated elsewhere and had to bring them up to speed. What helped and hindered them to take up these changes? That's implementation issues. The third level is division management. Now, I'm Research and Development Officer support to the Division of Primary and Community Health Care. We have 110 units, about 60, 70 are primary healthcare centers, and then we have psychiatry and specialist home visiting healthcare. So at that level, what helped and hindered division management to establish what they had to establish to respond to the pandemic? Or we could look at the whole region. We could have looked at how the region implemented changes in its public hospitals and in the aforementioned primary and community healthcare approaches. Now, one way to do an implementation study is to say, well, okay, we'll interview people and we will ask what helped and hindered you to take up the changes that you had to make? And by the way, what changes are we talking about here? And what helped and hindered changing? So you could interview people at different levels and do a study that way. We chose to focus on emergency management levels 1 and 2 and not look at the details of how service delivery units implemented these clinical practice changes. So what do I mean by that? How did we carry that through, and why did we choose that? Well, we defined the project purpose as research-informed implementation decisions. That was one of the things that we wanted to provide to the management teams and managers. They were very, very busy fighting fires, and we felt as researchers we could step back and give a more objective picture of what was going on across the region in their management levels. We also said that what we need to do is learn from this for our winter preparations, because there will be a resurgence and there'll also be an upsurge in neglected chronic disease and mental health issues. And what we learn about implementation will allow us to be more effective in the winter. We also aim to provide scientific knowledge, because this second purpose, I've cast it as knowledge about implementing emergency responses to infectious disease outbreaks. There is already fields of knowledge. Emergency management is a field with its own journal. There's public health emergency, but none of these related fields say very much about actual aspects of implementation, and we have a lot to contribute here. And I'm suggesting a subdiscipline of rapid implementation research. And this means moving out of the academic, our previous focus, I think mainly in academia, into the wild, and I'll talk more about that later. So the first challenge was, well, okay, if that's what we're going to focus on, what's the intervention? That always is the first thing, is to describe and define the intervention. Well, one part of the intervention was an emergency management structure, and I'll share that with you. The emergency structure was on the 1st of March, the regional government instructed us to form an emergency management group, following actually the NATO model for emergency management that we have in our crisis response plans. But this was the first time this group had been established in anger, and this group was new, and 2 meetings a day of the emergency management group, one at 9 and one at 2 o'clock every day, and we've moved this back to three times a day here in July. The emergency management group had powers to direct the operations management. Now, this is the normal operations management team of community and primary healthcare for the public groups. Later on the 20th of March, 3 weeks later, we were given the assignment to coordinate all of the community health and social services in the region. Now, 60% of the primary healthcare are private healthcare clinics, and a lot of the social care is provided by municipalities, and we formed what we call cluster organizations to bring these together, and that was a new and important innovation that we want to maintain to improve our coordination across these services in the future. The data we collected was 5 types of data. What I did was I put together a survey, weekly surveys that we did over the web, the internal region web, to all of our 110 facility managers. And these surveys asked them questions that were informed by implementation research, questions about what changes they've made, what helped and hindered them, and what they were doing to protect staff health. And we analyzed these and presented, basically we issued these on Friday mornings and analyzed over the weekend and presented them to the management team on Monday to give an overall picture to complement their picture, and presented them to the emergency management team to say, look, this is what all of the results heads are saying. They were getting feedback from the results head verbally, but this gave a broad picture in the weekly surveys. We also did interviews. There are lots of documents. I'll talk about the quantitative data and also say something about the media reports later. So moving on, what then is context? Well, context generally is everything that's not the emergency management and what helps and hinders this. So what we needed to do was collect information and data about the important aspects of context that helped establish the emergency response. And these were, in Sweden and the Nordic countries, law is an important one, with a whole range of mechanisms to implement the law. But if the law is passed, that provides an enormously important enabling context for the work. A second enabling context is simply the rising rates. of infection and death. And I think we've seen everywhere that as health professionals, this is what we do. This is our vocation. And the time has come for us to shine. And that esprit de corps was really an important context everywhere. We saw what our colleagues were doing in different services, and that brought us together. And I suppose the culture, the professionalism of clinical staff and managers was part of the context that enabled us to move fast. There was also the media, and I think the Swedish media were perhaps less dramatic than the international media, but we were aware of the BMJ as well as the general media coverage abroad. Our excuse in the primary and healthcare group was essentially, look, they're talking about the public health aspect of this. But we were also aware that the focus was on us also in healthcare providers. And I'll say more about that as regards the older people homes later. Now, the last of that four-way intervention, implementation, context, and outcome is, what are the outcomes of implementation? Now, obviously, the downstream outcomes are health, but we need more upstream ones that can be connected to the interventions that we were looking at. One of these is information and guidance. Did people get the information? Was it adequate? Did people get PPE? And were we able to implement the staff movements and staff training? Were the PPE and materials delivered? And we got some of these data from the weekly surveys to look at the outcomes of what the senior management team and emergency group were doing. Let me illustrate that in terms of implementation. What was implemented and what were the outcomes? Well, in terms of the actual implementation, one of the things was we were meant to rely on the national purchasing and distribution of PPE. And there was a small region unit for this. This simply wasn't working. And so what we did was we have contacts in Scania who built our new hospital and are still finishing it off there. And they volunteered mostly 20 staff who were experts in purchasing and logistics. And we formed a partnership unit, actually over the road at the hospital, that was staffed up to do the purchasing. And that there is Sarah Limbrone, who's one of our director of, actually a physician who was dragooned in to coordinate this with the Scania staff. And there were, so I think establishing and setting up and operating this purchasing and logistics unit was one way in which we implemented a system to actually procure the essential PPEs, and we didn't hang about, we just did this. And Scania were able to purchase using the government authorization for buying, as well as their own name and reputation internationally. And they were able to, had all the connections to fly in the materials. So we bypassed the national systems and just went to it. we got the equipment in, and then it was mostly volunteers distributing and packing for the different primary care and other services that needed them. And we had to allocate and prioritize, and I'll show you some of the data that we used to help do that, which is part of the implementation. One other thing that we already had the digital systems in place, but they were not used for video consultations and telemedicine. So the implementation was really training and giving guidance for people to use this. And this is one way to say, well, actually, that implementation, that was the result of the implementation was within 6 weeks, we were able to get over 1,000% increase. It wasn't just the training and patient guidance. I think there were other things going on there, but that's one of the outcomes of implementation. The second challenge was we were and are facing an evolving crisis. Every day there is new information that suggests changes that we ought to be making. And that's without mentioning the neglected chronic and mental health issues and health that will be deteriorating that we need to pay more attention to increasingly. With these daily changes, how are we going to document and present this dynamic, evolving? Remember, we're looking at context, we're looking at implementation. How would we present this and document it? And how would we sort out what influenced what? Well, we looked at the frameworks, and the obvious ones were Chambers' dynamic framework and Saldana's stages of implementation that were covered in this masterclass. But these are really for longer term, more serious and systematic research, and they were not really relevant to our rapid implementation research. We didn't have the resources, and these were too sophisticated, but they did give us ideas. Some of the other implementation concepts that helped was the behavior change taxonomy, Susan Nish's taxonomy, which reminded us that there are 93 different ways to change behavior. One of them, by the way, is the very useful wings that help keep social distancing, the golden wings, social distancing in the schools. Although actually an interesting argument or discussion would be, are the wings an intervention or an implementation of an intervention? I'll let you dwell on that one. Another one is the Powell et al.'s reminder that there are 93 different implementation strategies. I've just shown a few there. Again, this reminds us, it helps us identify which changes and strategies were used for implementation. And it reminds us to ask people questions. Did you use this? Did you use that? And think about, could they have used that? Would it have been more effective if we had used some of these? So what helped was essentially what we did was we chunked the collection and presentation of the research into, remember we were feeding, part of the research was feeding back regularly, but in terms of the overall report, phase 1 was starting it, phase 2 was the evolving response in May. We're in a transitioning period now where we have really 2 parallel systems, and then we will have the catch-up, smoothing and preparation in August and September. The smoothing refers to trying to smooth out the follow-up for the chronic illness and mental health issues. My target is a report to the team on the 24th of August with recommendations and the overall summary. Oh, and also this was a week ago, outside the hospital across the road, the new Karolinska Hospital, with a couple of nurses, well-deserved ice cream rest there. They've taken their face masks off, and I'll explain that some other time. The third challenge we faced was data for management decisions. And also this data was important for us to track outcomes. And we needed quantitative data to give feedback to the management team about what was going on. Our resolution was to combine databases. The national data were not sufficiently timely, and there were big discrepancies between what we were seeing on our daily data in our primary healthcare and in our hospital data. So what we did is we went to the real-time data and combined these in different ways, and I'll show you some of that in a moment. We also used a prediction model because our teams needed to know what to expect, and these prediction models take the infection rate and then predict what the impact is going to be on the hospitals. And we were able to, we used the Penn, we and a unit in one of the hospitals used the Penn University model algorithm and modified with our data with different assumptions. I'm not going to dwell on this, but this is just to give you a feel. What this shows is the blue is the actual daily occupancy in the hospital, and the of patients, tested COVID patients who deteriorated to the degree that they needed to be admitted to the hospital. The violet is the that is the Penn model prediction. So by comparing actual with predicted, we were able to modify the model for local. I can come back to this later if anyone's interested, but my main point at the moment is that these data were part of the things that were needed for effective implementation for planning. They're also important for us to show the region and others. What we've got on the left here is the daily people in care with tested COVID. So these are the daily registration. And what this is showing is the hospital. Sorry, I don't know what happened there. What this is showing on the left is all of the hospitals total. On the right is tested patients ill with COVID, tested, registered, being treated by our primary and community healthcare in our public sector. The point of this is to show the activity, and that essentially, if we had not been doing that with a vengeance in primary care, community care, that would all have been offloaded onto the hospitals and they would have been completely overwhelmed. And some people at the region didn't get this, and this was very important for showing what we were doing and the importance of what we were doing. As regards older care, the orange here is showing the number of people tested with the coronavirus who were within older residential care homes and home visits. You can see the hospital daily declines here, which is the blue, but there are more people in older care tested. And what we see here is a cumulative mortality in the old people care of 900. Now, this is almost half of all the deaths in Stockholm were in the care homes. And what I can talk about later is my first recommendation for zero infection in older people care home. And later I can talk about why and how that happened and how we can prevent that in the future by better implementation. But I won't dwell on that for the moment, because what I want to do is just summarize and lead us into the discussion. What we did with our implementation action research, or our rapid implementation research, was we presented these data and projections. This informed the decisions that the management team were making, and we were using these data later for our evaluation. So that was the point of the data. We also realized the value of the rapid learning experimental cycle. Now, many of you are familiar with this PDSA type of learning cycle approach. The learning cycle is used in many sectors. The approach we used, I called the 3R2D, define the problem, decide which data would indicate the problem solved, then you design the solution, and then you review the data to revise the solution. So it's an iterative, using the data to iterate the solution and repeat as the situation changed. And actually, this was simple enough and easy enough for our managers and staff to understand, and made it easier for them to use this when they were reviewing what they were doing, although there were challenges in the data. So what are the implications for implementation science? Well, I think what helped us to do this rapid implementation research was the fact that we had a long-term partnership between the region and Karolinska in doing practical research of this sort. This has established trust, and we'd established our value to these services. So we were not banging on the door saying, please, can we do some research? We were known, and people were prepared to work with us and give us time, even though all hell was breaking at the time. And we weekly provide value to the management team, who also helped make sure that we were able to get the data that we needed. Now, this may not always be possible in your implementation project, but if you want to do rapid implementation research in emergencies, those are some of the ingredients I think that would help. The implications for implementation science, well, we found that the methods were limited and the tools were limited for rapid implementation. There were some very useful ideas that informed what the model and approach that we developed for rapid implementation research. And the other lesson or thing that we discovered was that this wasn't a one-off emergency. This is an evolving crisis. So we still need implementation ideas and research for what's coming in the winter. And I think this is a tremendous opportunity for our science. I think we should develop, well, I'm not thinking, we are developing a subspecialty of rapid implementation response science. There's a group of us internationally working on this. We are not prepared to sit on our hands whilst we have knowledge and skills that we believe are useful if we can use them. So my question to you is, well, can implementation science continue to thrive in academic captivity? Or can we survive in the wild with clinicians and managers and find an ecological niche for our research and practice? And I would very much like to hear about what your experience with implementation research is for a COVID response, and your thoughts about whether we need a science, and what might be the best ways forward. And I'm going to stop there and hand it over.